call showtime.
The broadcast is now starting. All attendees are in listen-only mode.
You know the day destroys the night, night divides the day. Try to run, try to hide, break on through to the other side, break on through to the other side, break on through to the other side, yeah. We chased our pleasures here, dug our treasures there, but that's still recall the time we cried. Break on through to the other side. Break on through to the other side.
Good morning, everybody. That was Jim Morrison from The Doors, and I'm Dr. John Minarsik from Chicago. Today is Thursday. It's February 2nd. It's 2012. It's 9:01 in Chicago, and this is our 41st 2-hour global online medical school pathology session. Even though that was a really nice song that started us out today, you might recognize a pattern with all the music today. Usually I don't have patterns, but today everything we play during break and at the end will be from the really great movie Forrest Gump. It's from the soundtrack of Forrest Gump. Today, if you have checked the the Global Pathology Course Facebook page, I announced that we are starting in a whole new chapter of diseases of the heart. We have finished all 10 chapters of Path 1. We have finished 4 chapters of Path 2. So this will be our 15th out of 29 total chapters of Robbins, which means we're half done. Because you know the halfway point is not between Path 1 and Path 2. The halfway point is 5 chapters into Path 2, and that's where we are. So if you want to think of this as the midpoint of our whole stretch, our 41st session, it looks like maybe all of them might wind up being about 80 this year. There were only 70 last year, but maybe we're doing a more thorough job this year. This is a good time for the test because I really don't have anything else to say. So the first test question is, do you hear me well? And I'm saying a bunch of yeses. And the second question is, what do you see on your screen, which is the same as my screen? Okay, and everybody knows it's flowers. It's purple pansies specifically. Okay. Sometimes when you see, I don't know what you could see on your control panel, but you might see Jim Lou, and I'm not really Jim Lou, but sometimes when Jim is busy or his wife Lynn is busy, I sign in myself to save them some time and some hassle. So if it says Jim Lou is speaking on your control panel, that's not really true. I just have imitated the boss, and I have logged in under his password. Jim is the producer and semi-director of this program here, and he is also the big honcho behind GoPath. I also realized from our last session that I had this little tendency to sing during some of the songs, and when I played the movie back after the session, I realized that maybe my voice wasn't that terribly bad, but I was ruining the spectacular singer. So I'm not going to do that anymore. And I know you probably are too polite to remind me of that, but I even ruined this song for myself. So I'll try to keep my mouth shut during our singing times, unless I can't control myself. Let's talk about the personality of today's topic, the chapter on heart, chapter 15 out of 29. It's a big chapter. It's at least as big as vascular, maybe a little bit bigger. It's more graphic than vascular. It's not quite as logical in vascular in my thing. There's a lot more clinical information, though. And the thing I want to point out with you is when you wind up taking your rotations after your USMLD, you're going to be running around the hospital wards, and you're going to be learning an awful lot about heart. So the stuff that we learned today hopefully will be a background to it, much more so than what we learned in perhaps other chapters. You know, you're all going to be whipping that stethoscope around your head, and you're going to now understand some of the diseases that you're going to be looking for. There's our title page. And just like we said with the vascular chapter, that there's two kinds of vascular diseases. Number one, atherosclerosis, and number two, everything else. We could probably say the same thing about heart. There's two kinds of heart diseases. There's ischemic heart disease, and there's everything else. So probably at least half of what we'll be discussing in the next couple of sessions will be on ischemia. We probably won't finish the discussion on ischemia today. We may get into it a little bit, but we'll be doing a lot of stuff before it. And the first thing I want to do is generally show you the kind of topics we're going to be talking about. We're going to review a little bit of the normal cardiac anatomy and features that pathologists look for when they do autopsies. Then we're going into some of the general pathophysiologic severe adaptations of the heart, specifically heart failure. Differentiate a little bit between left and right ventricular failures. I know that's all logical. And then the topics, pretty much following the topic of many of the chapters of systemic pathology, starting out with the congenital diseases. We'll spend a lot of time talking about the three types of congenital heart diseases. Number one, left to right shunts. Number two, right to left shunts. And number three, obstructive, and someday I'm going to learn how to type correctly. The left to right shunts all have a D in their name. The right to left shunts always have a T in their name. And the obstructive aren't shunting at all. They're just usually obstructions of major vessels. We may get into the beginning, or who knows how much, of the ischemic heart disease, you know, the biggest killer in the entire world. And then probably by the time we roll around next week, we'll talk about the hypertensive, valvular, the cardiomyopathies or primary muscle failures, pericardial diseases, and of course, you cannot neglect tumors. And as you know, of all the organs that you will be seeing tumors of in your practice, probably tumor of the heart is one you may never see in your life because they're very rare. So, what are the normal features of the heart? Your heart pumps out about 6,000 liters of blood a day, and if you divide that into hours and minutes and seconds, and you know what your end diastolic volume is, and you know what percentage of your end diastolic or filled left ventricular volume is spit out with every beat. That's your ejection fraction. Normal heart weighs 250 to 300 grams, but I bet you when you did your autopsy or your anatomy session and you saw hearts from all over your labs, there probably wasn't a single one that was that small. They were probably all maybe 300, 400, 500. And that's because people that die, like the people that donate their bodies to science, usually die chronically, and they have a lot of dilatation, especially hypertrophy, because of progressively weakening muscles. So believe it or not, nobody believes it, but the normal heart rate is only 250 to 3. It might be hard for you to find one in a person that dies of old age, natural causes. Almost half of all the deaths that occur, we'll say 40% to be more precise, are due to heart diseases. That's twice as much as cancer, okay? So when you hear that everybody dies from either cancer or heart disease, it's really, they should say heart disease or cancer, because it's about twice as much. The thickness of the wall of the heart, the atrium, the various ventricles, is directly proportional to the amount of pressure it has to sustain. So let's make something really, really simple. If the average thickness of a left ventricle is 1.5 centimeters, and the average thickness of a right ventricle is about 1/3 as much, or 0.5, well, and then you did a cath on that patient, what do you think the pressure would be in that right ventricle compared to the left? Maybe about 1/3? Yeah, that's a good rule of thumb to use. So remember, a wall of the heart, atrium, is only as thick as it has to be. So there's your right ventricle, 1/3 as thick as the left, and the atria are not even half as thick as the right ventricle. So you could imagine that the thick maximum pressure in the atria is not even half of what it is in the right ventricle. You all know the concepts of systole versus diastole. I'm not going to go into that too much, but it would not be fair if we once again did not review Starling's law, which we've touched upon in a couple of other chapters. And rather than go into all the mathematics, it's best to think of it as functional. And here's what it says. The heart will pump out all of the blood that the venous return gives to it. That's Starling's law. So if the heart can't pump out all of the venous return that's given to it, that's generally the process by which we will be discussing heart failure. So heart failure is also a failure of Starling's law. People talk about big hearts, holes in the hearts. Cardiomegaly, general term for a big heart. Heart can be big for two reasons. One is that the volume of the lumen in the chambers is increased, generally due to fiber stretching, generally due to volume overload, but also related to pressure overload. That's dilatation. Now, the heart can also be big. In fact, in this case, not only big, but increased in weight because of hypertrophy. And that follows the same principle of skeletal muscle. The thickness of a wall will hypertrophy, in other words, defined as increased in organ size due to increase in cell size without an increase in cells, because myocardial cells do not multiply. So a hypertrophied chamber, whether it's left ventricle, right, or atrium, is always the result of having to deal with increased pressure, just like your biceps would hypertrophy if you had to lift more weights all day. The same physiologic principle. There's a heart, and you know, the radiologist, the people doing ultrasound, the cardiologist, they all have, you know, their idea of how thick certain chambers should be. Classically, when pathologists actually measure the muscle, they usually measure it about a centimeter below the AV valve, whether it's the mitral valve or tricuspid valve. And once again, the average thickness is 1.5 centimeters. Now, I know what you're thinking. You're thinking, well, yeah, but what about all those muscles and crevices? Don't you have to kind of average it out? And of course, the answer is yes. But the place where there is the least amount of variation is, once again, 1 centimeter below the mitral valve. So when you read a pathology report and the pathologist says, oh, the left ventricle was 2.3 centimeters, he's generally following the rule book in measuring it right here rather than averaging out. Here's another example of probably the same thing. And this is a nice view of the heart. You can see the papillary muscles. You can see the chordate tendineae. You can see the AV leaflet. You can see the trabeculae. You can see the aortic valve here. The three cusps. Maybe if you really had a good imagination, you can see the openings of the coronary arteries. You can see a lot of pericardial fat because that's where it's at. Let's review a little bit of the histology now. Almost all of the weight of the heart is myocardium rather than pericardium or endocardium. About 98, 99%, who knows. And it's all classically cardiac muscle. There's no other place in the body that has cardiac muscle. Cardiac muscle is so easy to differentiate from any other type of muscle because if you look close, you may see striations. I don't know if I see too many here. I think I'm imagining a few striations here and maybe here. But it also has the nucleus now in the middle of the fiber. And remember, a cardiac muscle cell is the same as a cardiac muscle fiber. And once again, they don't lay on top of each other like logs, like skeletal muscle. They interbranch with each other. And of course, it's richly vascular, just like skeletal muscle. Here are your intercalated discs with a slightly different stain. You can see where one cardiac muscle fiber is joining another one. And once again, you can see they are not parallel. They have these little interbranches between each other. Otherwise, when you look at them under electron microscopy, you can see the same general pattern of actin and myosin. You can see the sarcoplasmic reticulum. You can see mitochondria, which we're seeing here and here. These are all pretty evident, I hope. And you also see a few little black dots here and there, and you know that that's glycogen because, like the liver and skeletal muscle, cardiac muscle is very rich in glycogen. So we talked about the striations. We talked about the nucleus being in the center of the fiber rather than at the periphery like skeletal muscle. We mentioned the discs. We talked about the sarcolemma. We talked about the sarcoplasmic reticulum, which is like the endoplasmic reticulum of any other cell. We saw the mitochondria. We did not see endothelium yet, but we will because like every other blood vessel, including the heart, there's always a nice, theoretically, single layer of endothelial cells coating the luminal blood interface. Fibroblasts occasionally. Certainly a lot of fibroblasts if the heart has been infarcted, because then this muscle is generally just replaced with scarred tissue fibroblasts. We know that glycogen is very rich. And it wouldn't be fair if we didn't mention that somewhere along the line, especially in the atrium, there's some specialized cells that secrete I.mp4 or atrial natriuretic peptide, which of course kind of tries to pump out the water as a reactive process whenever you have heart failure and you're underperfusing your kidneys and it's generating the RAAS axis and you're having too much aldosterone. Well, this is the reactive process, is that your atrium, on the basis of stretched fibers because of water overload, will then release this hormone to try to diurese the body even more. I was able to figure out a way to take these little pictures here and turn them into very nice stretchable items without losing resolution. Here is the epicardium or pericardial fat, if you will. If you saw some mesothelial cells along here, you would call this visceral pericardium. Otherwise, the fibrous pericardium, which you can't see here, would be the parietal pericardium. Mesothelial cells here. Here's a big vein. And of course, the big arteries run in here too, don't they? And the big arteries generally perfuse half or more likely 2/3 of the myocardium. And then probably the inner third is probably perfused directly from the luminal side of the heart, which of course theoretically maybe you could see is a couple of nice end-to-end endothelial cells. So this is a classical heart muscle, and once again, if you want to understand why these fibers interdigitate with each other rather than are parallel to each other, like in skeletal muscle, it's because the heart doesn't contract in a linear fashion like skeletal muscle does. It contracts in a three-dimensional fashion. So these fibers have to be connected. There's some nice fat. There's some more intercalated discs. And here, I think I have another close-up picture. Very often, you ignore the fact is how richly vascular the myocardium is. But look, you see all those little red dots there? That's a nice little capillary right there too. You can see a nice little string of 5 or 6 erythrocytes. They're basically all over the place. If you look very carefully, there's probably one right there. Probably every single whitish interface between these fibers. Oh, look at this one here. Here's a nice little perfect capillary with a nice string of erythrocytes. You don't see the wall because all it is the thinned out cytoplasm of an endothelial cell, isn't it? So, let's move on. It would not be fair if we didn't talk about this specialized group of myocardial cells, which usually runs very much subendothelially or subendocardially, called the Purkinje system. These are specialized myocytes or cardiac muscle cells which have been specialized to conduct electricity better, and this of course forms the conducting system of the heart. These are Purkinje fibers. You don't normally see them, but if you think of them as looking like a little bit kind of ballooned out myocardial fibers, of course they don't have striations like the myocardial cells do. You'll see this very nicely. When you first see this, you think, what kind of degenerative process is this? Because you don't see it very often. When you do see it, you should know this is just normal Purkinje cells. Another thing to remember is that a lot of times when we do autopsies for the clinicians, and they're very big on EKGs and arrhythmias, and they know the patient had a certain arrhythmia, they ask us, well, did you see a lesion in one of the Purkinje fibers? And we kind of laugh at them saying, are you kidding? We hardly ever see Purkinje fibers, and it'd probably take a year just to cut that thing enough to look at all of them. So let's move on. Does this look familiar? Here we are, the entire right coronary artery system going to the right, the entire left coronary artery system going to the left, the circumflex branch soon branching off of the main after about 1 centimeter. Everything else, the LAD, which everybody calls LAD, but the anatomists call it the anterior interventricular artery. I don't know why they're trying to change it. It's not working. And of course, what we call the PDA, the posterior descending artery, is now called the posterior interventricular artery. And that's usually formed by the right artery branching around and coming down. Maybe like the majority of the time, like maybe 60-70% of the time. And when it does that, it's then called the right dominant coronary artery. When the main part of the posterior descending or posterior interventricular comes off of the left, like you see here, then that's called a left dominant, and sometimes it's codominant, where you see both. This would probably be what I would call more of a codominant, because that artery is really the result of both. Remembering that the right sends off a tiny little branch going to the sinus node, a very important branch because that's what feeds the initiator of the conduction process of the heart. So cardiologists always consider the patient to have 3 coronary arteries or triple arteries. So that's the LAD, the circumflex, and of course the LAD and circumflex are all part of the left main. And then that big right, which feeds, usually has a good marginal branch. And remember, this is not the septum along here, this is the right ventricle now. So that's basically how you call it. You just keep your orientation of left and right. That usually winds up perfusing the myocardium. Now, in this, what was usually called thallium scans a generation ago, now they're called hexamib or sestamib because they're technetium compounds. You can see good myocardial perfusion. Here's like the pathologists cut the heart, the bread loafing of it. They cut it from the apex going up towards the base. So that would be the anterior wall. That would be the posterior or inferior wall. That would be the septum, and that would be the lateral wall. And now you're just cutting up. Now if you cut the heart with a knife or a computer along its horizontal long axis, you are then slicing from the septum towards the lateral wall, so you get a nice view of the anterior and inferior walls. And if you cut it in its horizontal long axis, here's the vertical long axis, here's the horizontal long axis, then you're slicing it from the anterior wall to the inferior or posterior wall, if you will, and you are then getting much better views of the lateral wall and the septal wall. And almost all of this perfusion activity, by the way, is left ventricle, because I would probably like to guess that maybe 80% of the myocardium is left ventricle. So there's really not much that you see on the right. There's maybe a little shadow of right ventricular activity there. I wouldn't know for sure. The valves, one thing that people don't normally care about or do, except pathologists, is actually measure the circumference of the valves, because chamber dilatation is awfully associated with valvular dilatation, or stenosis would be less. And one good way to remember it is that the AV valves are a few centimeters more in circumference than the semilunar valves. In other words, the tricuspid and the mitral are considerably bigger than the pulmonic and aortic. And always remember that the right side is bigger than the left side too. So a tricuspid valve, because it has 3 cusps, is about 13 centimeters. Some people say 14, some people say 12, but say 13 is generally a good average. Always remember the mitral as being a couple less, and it's also a couple less in your semilunar valves as well. So a pulmonic valve, remember right is always bigger than left, is about 8 centimeters, and of course the aortic is a couple less. And technically you would probably call these tricuspids as well, because they have 3 cusps usually. Sometimes they have 2. But the tricuspid valve is specifically reserved to the atrioventricular valve on the right side. Okay, let's get a little bit into general diseases. Your heart ages just like you age. There are certain predictable pathologic findings that you see in hearts, and I'll kind of outline the main ones over here. As a heart ages, you generally have an increase in the left atrial chamber or cavity size. And remember, we said that increases in chambers or dilatation is the result of volume and or pressure overload. So let's say that person was in failure and that the left ventricle couldn't keep up with the pulmonic stuff that was being sent to it. Well, chronically, wouldn't you expect an increase in left atrial cavity size? And here is another interesting thing. Very often a decreased left ventricular cavity size is noted, often from the simple geometric fact that the left ventricular wall is thickening. So if you have a left ventricle and the wall thickens, geometrically speaking, not even medically, the left ventricular cavity generally would decrease. Now, of course, if there was significant volume overload in that entire heart, you probably wouldn't see much decreased left ventricular cavity size. You could even see increased out of proportion to the hypertrophy. And for a reason I really can't understand, but I bet you somebody can, the ventricular septum being rather straight becomes sigmoid or tortuous due to uneven pressures, just like the aorta becomes tortuous when you get older. And here we go. Guess what? The coronary arteries also get tortuous when you get older. And remember now, we talk about cardiac aging, we're not necessarily talking about atherosclerosis. And do you remember when we talked about veins, varices, we said that varices are not only tortuous, but they're dilated? Well, if you subtract the atherosclerosis factor, you actually have not only a tortuosity of the coronary arteries, but increased cross-sectional luminal area. Remember, atherosclerosis decreases it. Calcific deposits in the heart could be part of atherosclerotic plaque, but even without atherosclerosis, you can get buildup of calcium in the heart, in the coronary arteries, but especially in the aortic valve. So aortic valve calcification is regarded as relatively independent of atherosclerosis. You can also get a lot of calcium deposits in the mitral valve. So the left valves generally love to accumulate calcium as you get older, and with that, perhaps a fibrinous thickening of the leaflets as well. And think about it. There's also very often described at autopsies a buckling of the mitral leaflets towards the left atrium as well. Myocardium, with aging, gets bigger, increased mass. It's almost very, in fact, it is very, very rare to see an old person dying of a chronic disease, perhaps not even related to cardiac, where he has his technically normal 250 to 300 gram heart. They're all bigger. That's why people think that the average weight of a heart is 500 or 400, because they've done a million autopsies, but it's actually only about half that. And of course, as the body gets fatter when you get old, like mine, some of that fat builds up subepicardially as well, where the coronary arteries run in. We're going to be showing you a nice microscopic, a universal disease called brown atrophy, which is a buildup of a certain kind of pigment in the myocardial fibers, and this pigment is called lipofuchsin. There's another pigment that builds up, a glycogen-related pigment, which is called basophilic degeneration, also a normal or widespread common aging factor. And remember, we also told you in the chapter on immune diseases that amyloidosis does not just follow multiple myelomas and chronic granulomatous diseases, that it's a normal buildup in the blood vessels of everybody that ages. So you have amyloid, I guarantee it. I probably have twice as much as you do. But do you sort of remember, going back to one of our pictures here, which I'm going to show you again, is that when we were looking at some of these pictures of the normal heart, remember we called this normal, and it is normal. But here, let me show you something. You see this? Here, I got to find out if you could really see this. Do you see these little granules just on that side of the nucleus there? Yes or no? Yeah, you can. And here, let's take another one. Ooh, they're very subtle sometimes. Oh, that was the best example. Well, believe it or not, that's a little bit of lipofuchsin pigment. That's brown atrophy. It's so common that you don't even look upon it as being abnormal. And it almost never causes clinical or cardiac diseases. It's just a normal aging pigment. And if you remember, I told you that there's three kinds of golden refractile intrinsic pigments that are common in the body. So if you see something that's golden and refractile, it's probably an intrinsic pigment like melanin or bile or hemosiderin. Well, this is the fourth one. I didn't mention that, but you see, there's the nucleus again, and there's granular stuff there that's brown. And see, there's a nucleus, and there's granular stuff there that's brown. Well, this is lipofuchsin, and believe it or not, even for this relatively, what you think is a relatively small amount of pigment, that myocardium actually looks browner. Here's a electron microscope view, and the one thing you may remember or know is that the nucleus of a cardiac muscle cell is often very, very squiggly. It's not nice and round and oval. It's more like a Le Mans racetrack rather than an oval at a horse race stadium. And there's the buildup of the lipofuchsin pigment. Very, very common. Let's go back and look at cardiac aging with the aorta. And I hope that this is logical too. Just like we said that the coronary arteries get more tortuous and more dilated with aging, even independent of atherosclerosis. So does the aorta. So it's very, very common for a radiologist to look at a chest x-ray and say, there's a tortuous aorta. It's very, very common, but he mentions it anyway. And all that means is it not only longer than it should be, but how could it be longer if the patient isn't taller? Well, the way it becomes longer if the patient isn't taller is becoming tortuous. And let's see if I could point that out over here. Oh yeah, take a look at this. This is a nice, it's a good thing that there's a lot of calcium in the wall of this aorta, otherwise you couldn't see the edge very well. But look at, you know, after the arch comes, it basically is supposed to go straight down. But look, it's curving here. That's a tortuous aorta. It's dilated, it's longer, and it's probably doing the same thing the coronary arteries are doing, or varices do, or varicose veins do. Another place where calcium loves to deposit, remember we said it was the aorta, and the most likely place, or the earliest place it will deposit, in the so-called sinotubular junction, which is right above the leaflets of the aortic valve. You see, there's the right coronary ostia, and there's the left coronary ostia. Here are the cusps of the aortic valve, and that's right above those cusps, the so-called sinotubular junction. That's where the calcium loves to go when you get older. Of course, with degeneration and perhaps atherosclerosis and aging, those nice concentric, parallel, squiggly, elastic fibers, we saw a picture of that in the last chapter, they become fragmented. Your aorta becomes less elastic. It goes from a new rubber band into an old rubber band, which is not quite so elastic anymore because of the disruption of the elastic fibers. And last but not least, atherosclerotic plaque. Now, I don't want to get into this, but atherosclerosis is so common, if you wanted to include that as normal aging process, I wouldn't fight with you. But remember, we're talking about diseases. Atherosclerosis is a disease, but it's so common in elderly people that a lot of the features we see in aging heart can be explained or due to atherosclerosis. So whether it's a separate disease or normal aging, that's for the philosophers. We're here to teach medicine. Okay. Let's talk about the general ways. Just like we talked about the soda straw. The soda straw could, in a blood vessel, could either break or become clogged. So let's talk about the big pumping soda straw called the heart. Let's look at it mechanically. Let's look at it logically. Well, the wall of that big, thick soda straw, the myocardium, can develop a primary disease such as amyloid or infiltration, accumulation of substances like glycogen, or primary genetic problem causing the cells not to function as well. That's a myopathy or a cardiomyopathy. That's primary muscle failure. Another possibility within that big, thick, chambered soda straw is for a valve to become thickened or not allow the fluid to go through. That would be a valvular problem. Another type of valvular problem is not necessarily for the valve to become thickened, but to become incompetent, and therefore perhaps it's not closing properly, and therefore you have backwards or regurgitant flow. These are all just anatomical or geometrical considerations, but I think they really are good when you talk about the heart. Another thing is to remember is the heart has a conduction system. You have the AV node, you have the SA node, you have the bundle of His, you have the Purkinje fibers, and something can go wrong in that, either generally or focally. And really the most common reason is to have part of an infarct or ischemia in that area. And remember, these all run subendocardially. And of course, you can also have failure of the wall of the heart to contain blood. Okay, so you can have rupture, and that's very, very common with transmural infarcts, which involve the entire thickness of the myocardium. So these are the possibilities. And we're going to be talking about these in the different classifications of disease. But we also have to talk about another general process of failure of the heart to any or all of these. And that's called congestive heart failure. And the one thing you'll learn right today, as well as in the clinics a million times, is that there's 3 parts to all congestive heart failure. Just like there's 3 parts to diabetes: polyuria, polydipsia, polyphagia. Well, there's also a triad for CHF as well. It's tachycardia, increased heart rate, dyspnea, or difficulty breathing, and edema, or accumulation of fluid. That could be in the systemic area if it's a right heart failure, or it could be in the pulmonary area if it's a left heart failure. And it's usually never exactly one or the other. Usually it's a combination or both. Congestive heart failure is due to the failure of Starling's law of the heart. Congestive heart failure is when it can't keep up with the law. And the law says that your heart has to pump out all the venous return that's fed to it. Well, when it can't, that's the beginning of congestive heart failure. Well, why is there tachycardia? It's because if it can't, it tries to speed up to do it. Why is there dyspnea? Very often because there's congestion in the lungs, and you also fight to oxygenate your blood more because less of it is going to your peripheral tissues because of cardiac reasons. And of course, edema is both anatomic and physiologic. Edema is due to the Frank-Starling mechanism. If your venous return can't be pumped out, it backs up. That's the anatomic concept. But more likely, the concept is physiologic, because in congestive heart failure and failure of perfusion to your kidneys, you kick off that renin, angiotensin, aldosterone axis, and you start to retain sodium and retain water. And that's another explanation for the edema. Oh, there's humoral factors. We talked about the renin, angiotensin, aldosterone axis, RAAS. We know that what happens is that when there is volume overload because of this axis being triggered off, the fibers in the atrium are stretched to produce atrial natriuretic polypeptide, or AMP, and that does the opposite of what aldosterone does. So both of these are elevated in congestive heart failure, and of course the catecholamines kick in to speed up the heart. Also, anatomically speaking, the heart becomes bigger, and the heart becomes bigger for 2 reasons. Because the chambers are dilated, that's called dilatation, and they're dilated because of failure of the Frank-Starling mechanism and buildup of volume, but they're also due to hypertrophy. And one of the main explanations for hypertrophy is that when there is volume overload, there's pressure increase. And therefore, like any other muscle, when it has to do more work because there's more pressure, the only thing it could do is hypertrophy. It can't hyperplase, right? There's no mitotic spindles in those cardiac muscle cells. So the only thing it can do is become bigger, get more fibrils per cell rather than increase the number of cells. So in a cardiac hypertrophy, you can have a hypertrophy in pressure overload. The most, besides hypertension, of course, which would be the easiest way to think of it, if there was a valvular problem obstructing that flow, there would have to be increased pressure to go through that obstruction or stenosis or valvular problem. That's one consideration. But the other explanation, like we said, for hypertrophy is because if there's an increased volume, then you have an increased pressure because of that increased volume, right? The bigger you blow up a balloon, the more tension there is on that wall. And of course, this hypertrophy could be at the left or the right ventricular atrial level. It all depends on where the hypertrophy is. Now, if you have primary muscle failure due to any reason, and you can't keep up with your venous return, wouldn't that be one way to understand why your atrium might become hypertrophic as well? Because they're trying to pump more of that into the ventricles, but the ventricle can't pump out enough. So generally a hypertrophic heart now is an enlarged heart. Dilatation does not increase your heart weight, because all it is the chamber that's enlarged. But hypertrophy does increase your heart weight. So if we told you that the normal weight of a heart, once again, 250 to 300 grams, and all of a sudden you got an increased weight, most likely that's due to ischemic heart disease if it's 2 times normal. You know, let's say 4, 5, maybe up to 600. After about 600, and now you're about 3 times the normal weight, now you're probably dealing with hypertension. And because of the increased left ventricular primarily workload to produce or keep up with that hypertension, you're going to have hearts now that are like 5, 6, 700. When you get hearts that are, you know, pushing 1,000 grams, you know, primarily left ventricular, but myocardium in general, you're probably thinking of a myopathy, because in many of the so-called infiltrative myopathies, whether they're infiltrated by amyloid, whether they're infiltrated by leukemic infiltrates, whether they're infiltrated by buildup of substances like glycogen, we're now talking about hearts close to 1,000 grams, and or maybe an aortic regurgitation in which there's very significant increased pressure. These are all things that would be considered about 3 times the weight. So what's the general rule here? Normal heart, we'll say 250. Twice as much, probably ischemia. 3 times as much, probably hypertension. More than 3 times as much, probably myopathy or aortic regurg. And some of the greatest left ventricular thicknesses are strictly due to aortic stenosis too. Because in an aortic stenosis, you need significantly more pressure to produce enough perfusion to keep that patient alive. Here's some nice myocardiums. Here's one that's cut along a long axis, and you can see that the septum here is extremely thick. The lateral wall is extremely thick, and I don't know, I probably should have had a little centimeter ruler put there, but this is a hell of a lot more than 1.5. This is probably 3 or 4. This could very easily be a cut from that, because now you're cutting along the short axis of the heart. And of course, the smaller that short axis cut is, the more you're bread loafing it towards the apex. Of course, the more you're cutting it when you get the larger volume of the left ventricle, the more you're cutting it towards the base. So what can you say about all of these? Well, up here you can see there's significant left ventricular hypertrophy. Up here you could say the same thing. Up here you could say the same thing. Now I don't have a centimeter ruler, but if this was more than about 1.5, I'd call that hypertrophy as well. But to me, this looks like significant dilatation as well. So the heart is enlarged for 2 reasons: hypertrophy and dilatation. Hypertrophy produces increased weight, dilatation doesn't. Here's a nice diagram. I normally don't like diagrams like this, especially if they have too many arrows, but I think this is a pretty good one. Think of hypertension as producing pressure overload and therefore increased cardiac work, and therefore the cells have to work harder. They're stretched, just like your muscles are stretched when you lift weights, and that'll produce a hypertrophy. Now, in valvular disease, especially if there is obstruction to flow, that'll produce increased fiber stretching as well, and also increased dilatation. In congestive heart failure itself, you're going to have increased volume overload because of the inability of the heart to pump out atrial blood into the system. So in an infarction, or failing hearts in general, you can have regional dysfunction with volume overload as well. The end result is that the heart becomes bigger, hypertrophy and or dilatation for whatever reason. When it hypertrophies, you get more cells, you get bigger cells, and not only do you get bigger cardiac cells or cardiac fibers, but guess what? The nucleus becomes bigger too. And not only become bigger, but they become more squared off, or so-called boxcar nuclei. I think I'll show you a picture of that. So these are all the things that happen. Of course, end result, cardiac dysfunction, end result of which would be failure, or arrhythmias, or pumping out of neurohumoral substances to compensate for the cardiac dysfunction. The autopsy findings in congestive heart failure: enlarged heart, generally cardiomegaly, chamber dilatation, which won't increase the weight, but the hypertrophy of the fibers does. And I'm going to show you a really nice, beautiful picture of cardiac muscle fiber hypertrophy. It doesn't matter what chamber this was from. I think I could convince you that these are cardiac muscle cells, because number one, you see the interconnections. Maybe something like that would be an intercalated disc or there. Let's see if I could. Can I try to convince you that there's a few cross striations there? You don't have to believe me, because I'm having a hard time seeing it myself. But the nuclei are in the middle of the fiber. And look at, in hypertrophy, for the nuclei that you can see, they're generally bigger and darker. Look at, that's a bigger, much bigger than average nucleus. And do you see how it kind of loses its overall oval configuration and becomes more squared off? You see how that one is almost like a rectangle rather than an oval? This one is still a little bit oval, but it's big. So these are to show you that in cardiac muscle fiber hypertrophy, not only do the fibers enlarge. By the way, these fibers are twice as thick as they normally are too. Too bad we can't put a little ruler there to prove it, but they are. When you look at them relative to the size of these capillaries over here, see all these little red cells that look like they're in the middle of nowhere? They're actually in capillaries. See, there's a capillary, there's one, 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 there's one. So that's cardiac muscle hypertrophy. Okay, you've been working hard. We covered a good amount of material. What we'll cover after the break are the different concepts of heart failure in terms of left versus right side, and then go into the congenital heart diseases as well. I don't know if we'll get into the ischemic ones today. So what I'll do is I'll pop down the window, and I'll feel like I did a good job. I know I was talking a little bit fast today. In fact, maybe I should ask you the question. Can I just ask you a very humble question, and I try not to hurt my feelings too much? Was I talking too fast today? Okay, well, I'm hearing a bunch of no's, 4 in a row, so I guess I don't feel so bad. Sometimes when I start my coffee more than 10 minutes before the class, I can kind of rattle off a little bit too much. So once again, all the music we hear today, the 3 during break, the one that at the beginning and the one at the end, they're all from Forrest Gump. So let's play one of my favorite protest songs of the 60s, and see you in 10 minutes.
Something happening here, but what it is ain't exactly clear. There's a man with a gun over there, telling me I got to beware. I think it's time we stop, children, what's that sound? Everybody look what's going down.
times being wrong. Nobody's right if everybody's wrong. Young people speaking their minds are getting so much resistance from behind. Time we stop. Hey, what's that sound? Everybody look what's going down. What a field day for the heat. 1,000 people in the street, singing songs and a carrying signs, mostly say hooray for our side. It's time we stop. Hey, what's that sound? Everybody look what's going down. Paranoia strikes deep into your life, it will creep. Starts when you're always afraid. Step out of line, the man come and take you away. You better stop. Hey, what's that sound? Everybody look what's going down. Stop. Hey, what's that sound? Everybody look what's going down. Stop. Now, what's that sound? Everybody look what's going down. Stop. What's that sound?
On the road again, just can't wait to get on the road again. The life I love is making music with my friends, and I can't wait to get on the road again. On the road again, going places that I've never been, seeing things that I may never see again. I can't wait to get on the road again. On the road again, like a band of gifted, we go down the highway. We're the best of friends, insisting that the world keep turning our way, and our way. On the road again, just can't wait to get on the road again. The life I love is making music with my friends, and I can't wait to get on the road again.
Well, we're back. I think the first half went pretty well. I feel pretty good about it. I never do as much as I think I'm going to do. This is a good time to ask you again another little question. And was everybody able to hear okay in the first hour? Okay, now let me ask you another question. And remember, I don't know your names. Okay, when I look at all of these things, I don't see anything except the answers. I want to ask to you, for those of you who are near your keyboards, to just type in your age. Just give me a number. Okay, you don't know what you're all saying, but I'm seeing a nice range of ages here from the early 20s all the way up to 60. And so some of you may remember the so-called Vietnam era, but probably most of you don't. I certainly do, and that's why I played that Buffalo Springfield song describing a country that was very, very spooky because of a lot of suppression against protest. You know, much of the same things that we're having now. And in addition, it seems like the more this country that I live in, USA, is getting into financial problems, the more repressive it's becoming. And it seems like a lot of this Vietnam feeling is coming back again. Okay, well, that's all I have to say by way of political rebellion. So we know that the audio and visual is working, so let's continue now into the second half, because I really had nothing else to think about during the break. The concept of left versus right heart failure is very, very, very logical. And for some reason, it's never mentioned in discussions of it, but if your left heart is failing, and let's say primarily left ventricular pump failure, then what's going to back up, according to Starling's law, is going to be your pulmonary venous circulation. If your right heart is failing, right ventricular, theoretically, the primary area of Starling backup or Starling failure is going to be your systemic. So we described symptoms of left-sided failure and right-sided failure. We're talking about anatomical necessities. Like in a left-sided failure, your primary congestion is going to be in your lungs. Right-sided failure, your primary congestion is going to be systemic, you know, legs, liver, stuff like that. A left-sided failure, we generally call low output failure. Because of the low output and the Starling failure, you have venous congestion in the veins that drain into that left side, which are pulmonary veins. Of course, if it's an acute process, you will see microscopically just considerable congestion, maybe some edema as well. The more chronic it gets, and the more that blood leaks out into the alveoli, and the more that blood then breaks down into hemosiderin, the more likely you are to see heart failure cells, which are hemosiderin-laden macrophages. Of course, in a low output failure, you're not perfusing your body. A good part of that cardiac output or body output is kidneys. So once again, underperfusion of the kidneys kicks in that juxtaglomerular apparatus to produce renin, eventually going into angiotensin 1, angiotensin 2, then aldosterone, which of course is going to retain the sodium and retain the water and furthermore increase the congestion, even though you're going to have a reactive process with pumping out of your natriuretic peptides. Okay, well, the ultimate sign of a failure, progressive, would be irritability. You know, once the brain is affected, you know that's basically, you know, the last organ to be affected. So it's not surprising that in left-sided failure, the terminal events are stupor and coma. Okay, so when you start to get CNS symptoms from heart failure, you know it's pretty advanced. So think about it. If you have a left heart failure and you have an inability to pump that pulmonary venous blood into the left systemic side of the aorta, you're not going to be breathing very well. You're going to have dyspnea, shortness of breath. If it's mild, it may be only on exertion. It may be after running up a couple of flights of stairs. If it's severe, it could be at rest without being exerted at all. So you know that this is a lot worse than this. Orthopnea is pretty much the same as dyspnea, but it refers to the comfort of breathing during sleep. So if a person gets a little bit short of breath, unless he has 2 or 3 pillows, that's orthopnea. And of course, the more the pillow, sometimes the measure of the degree of heart failure, primarily left, is the number of pillows that are needed. So if an older guy like me has been sleeping fine on 1 or 2 pillows and all of a sudden he needs 3, something's going on. Paroxysmal nocturnal dyspnea, it's not really a specific disease, it's just a symptom. It means paroxysmal means sudden, and sometimes that dyspnea can occur in the middle of the night with no exertion, and that's also a common symptom of left-sided heart failure. Here it is graphically, and pretty much the same as what we said before. Because the left heart is failing, the primary pathologic processes are in the lungs, including cyanosis, because of ultimately inadequate oxygenation of blood. And the cardiologists like to measure it by doing a PCWP, or pulmonary wedge pressure. Think about it. If your heart is failing, primarily left-sided, and I want to tell you, it's not many heart failures that are just primarily left-sided versus right-sided. It's usually a combination of both, but we're just describing the 2 extremes here. So because you can't really stick a catheter to measure that pressure inside of the pulmonary veins, think about it. It's an awfully hard place to put a catheter into. What they do is they go into the veins, into the right ventricle ultimately. And here, this is even a better diagram. What they do is go into the right ventricle, go up through the pulmonary artery, and stick a little balloon catheter as far into that as they can. They wedge it in, okay? It's not in the main pulmonary artery, and that's a very, very good measurement of PCWP. The catheter that does this is a balloon-tipped Swan-Ganz catheter. It has to be done by an expert. You hear of people that kill people because they're not experienced in Swan-Ganz. You'll always hear a couple of those. And so the measurement of the pressure, theoretically, pulmonary wedge pressure, not exactly the capillaries, but as close to them as you could get, is only about 2 to 15 millimeters. So if it's elevated, you can measure the degree of left heart failure. That's probably a single best measurement. It's probably why it's worth going through that. Of course, your therapies are going to be looking at how to reduce that pressure, just like your therapies for a right heart failure would be how to reduce the central venous pressure, which also has its limits as well. So let's talk about the right side now. Etiology, well, probably the same as left heart failure. Heart failure due to any reason. One really common reason for the right heart failure is to have severe chronic lung disease, because the more severe your chronic lung disease is, the more of a strain it is on that right ventricle because of fibrosis, because of narrowing of the vessels. That's probably the single most common cause for right heart failure. And of course, if the right heart failure fails now, the venous blood that can't be pumped due to Starling's law is from the systemic circulation. That's just an anatomic fact. So you'll have congestion in all the areas that drain into the venae cavae, okay, like the spleen, like the liver, like the soft tissues, like ascites, like the extremities. And also, you're very possibly going to be producing an effusion in the pleura and pericardium with a right-sided heart failure rather than the left. I'm still trying to figure out the reason for that, but remember, the peripheral tissues are also congested and edematous. So like people with a primarily right-sided heart failure are going to have edema in their extremities as well. Here's the lung, that's predominantly left. Here's the right on the bottom, that's congestion in the liver, chronic congestion, grossly, chronic congestion microscopically, and of course edema and congestion in the lower extremities as well. That's what they call pitting edema. It means the leg is swollen, you stick your thumb on it, and you notice it doesn't come back. It might take 5, 10, 20 minutes to come back to its normal unpitted state. That's like a very, very, very common clinical thing done every day, and all the medical students do it when they are looking at their CHF patients. I'm sorry, but in almost every pathologist presentation of chronic congestion of the liver, they show a picture of a nutmeg. Because if you cut open nicely a nutmeg, it almost has the same pattern of linear brown and lighter areas. And so that's why they call chronic congestion a nutmeg liver. And remember, if the liver is congested chronically, what are the portions of the hepatic lobule that are the most sensitive to anoxia? Is it the portal area, or is it the central vein area? Well, the portal area gets the earliest part of the portal and arterial circulation, but the central vein is the last part of the liver to get oxygenated. So that's the part that becomes necrotic. So when you look at a liver microscopically, and you can see there are some areas here that look like viable hepatocytes, but then there's these granular, yucky, crumbly, necrotic areas. It's probably the necrotic areas are going to be in the region of central veins, and the parts that are well preserved, you'll also see portal veins and maybe portions of hepatic arteries and bile ducts around them. They're relatively preserved. So that's logical as well, because it shows us that in an anoxic, congestive condition, lack of oxygen, the part of the liver that's going to necrose first is the part that gets the blood last, and that's the central part of the lobule. Another thing I want to point out with you, and I'm thinking I'm going to pop open the window for this because it's very important. Can you see very specific, pinpoint, single, individual red dots here? Those are portal veins. So if you were to put this area under a microscope here and actually look at those red dots, those would be congested and maybe even necrotic portal vein areas. And that's amazing, because I love to go from gross to microscopic. So if your eyes are good enough, you know, most hepatic pathologists walk around the lab with a magnifying glass in their pocket, especially when they go to autopsies. But when you see one single individual pinpoint red area, that's almost certainly a congested central vein. So you're going from your eyeballs to microscopic. That's really a cool thing to do. Okay, graphically now about right-sided heart failure is that because now the systemic vena cava circulation is suffering due to breaking of Starling's law. Patient will have fatigue, you know, which of course will be in many of the heart failures. They'll have dependent edema, or edema in the gravity-dependent portion of their systemic circulation, like we saw the pitting edema in the feet. They'll have jugular vein distension. Okay, that's also a fairly specific right heart finding. They'll have hepatomegaly because of the congestion. They'll have possibly ascites because of the congestion. And that's not even if they have significant liver disease or not. They may have a pleural effusion because of the systemic congestion. They'll have congestion in their GI organs. And just like with left heart failure, there may be some cyanosis, not because of shunting of blood, but once again, because of inadequate oxygenation. And just like we talked about the pulmonary wedge pressure is being elevated, you know, with the Swan-Ganz for left failure, well, in right failure, it's much easier to measure. Even you could do that. You don't have to be a cardiologist with the Swan-Ganz experience. All you got to do is somebody that knows how to get into a vein, put that catheter here. Let's see if we could blow it up for you. Put that catheter to a regular brachial vein all the way into the brachiocephalic, then all the way very close to the vena cava, where it should be sitting there. And that's your central vein. So central venous pressure is also pretty low, milligrams of mercury. It's only 2 to 6. It's not that much different from pulmonary wedge pressure. And in patients with heart failure, it's usually significantly higher than that, 10, 20 even. So the measure of your therapy for that heart failure, your digitalization and everything else, the single best measurement to see how your therapy is going would be to measure that pressure. And that's going to tell you how good your therapy is going. Okay, so much for heart failure. Now, if you remember, we talked about the general types of heart diseases now. We talked about congenital, which is often abbreviated CHD, which is confusing because a lot of people think that means cardiac heart disease or coronary heart disease. It does. It's congenital heart disease. Very interesting topic, which we'll probably finish today. The main type of heart disease due to atherosclerosis of the coronary arteries is ischemic infarcts and ischemic situations. There's heart diseases due to hypertension itself. There's heart diseases due to valvular diseases, whether it's obstruction or regurgitation. And of course, there's heart disease due to primary muscle failure, independent of all these other things. And these are called myopathies or cardiomyopathies. And there's a nice little differential of that. So let's talk about the congenital heart diseases first, because I'm sort of proud of this. Whether it's going to come off very nicely or not, I don't know, but I've been thinking about this for a long time, and I think I could summarize this nicely. Most of the congenital heart defects, congenital heart defects are one of the most common types of congenital defects. 1% of all babies in the United States have some type of congenital heart disease. Remember when we talked about the pediatric diseases, we said that VSD and PDA, or ventricular septal defect, and patent ductus arteriosus were 2 of the 3 most common congenital defects. And clubfoot, I think, was on the list as well. But most of them are not due to single gene mutations. Most of them are just due to a faulty embryogenesis, some defect during the embryologic process. And if you remember, the heart, the critical time for heart development is very, very early in pregnancy. It's usually a couple weeks, 3 to 8 weeks. When you could barely see the baby, you already have important forces to make sure that the heart is developing properly. They're usually not due to a single lesion, but they're due to, they're usually not due to a single gene, but they're usually monomorphic, which means it's usually only one thing, like a single ASD or a single VSD, atrial septal defect, ventricular septal defect, hypoplastic right ventricle. All these things we're going to be talking about. Usually when they have one, they don't have another one. Sometimes the reason why they can't have another one, it would be anatomically inconsistent with life. In many cases, like the atrial septal defects, which my nephew had, as well as coarctation or significant narrowing of various parts of large vessels like the aorta, you don't even know you have it until you're in the adult life. They're very easily detected now that we have things like ultrasound, CT, catheterization, so a congenital heart defect could be picked up very nicely by even relatively non-invasive methods. Now, here's the easy part. Hopefully, this is like I bake a cake for you, and I hope you like it. All of the congenital heart diseases can be divided into 3 groups. Look, there's about 10 things on the list here, but there's only 3 types. One of them, the ones in red, are the right to left shunts. Whoops, guess what? I screwed that up. I made that red, and that should be purple. I don't know how that happened. Okay. And of course, the left to right shunts all have a D in their name. The right to left shunts all have a T as a major portion of their name. And the reason why I made the right to left in purple is because these are blue babies. They are cyanotic babies. When you have significant right to left shunting and you're bypassing the lungs, that produces cyanosis because a large portion of your blood is not being oxygenated at all. That's called cyanosis. And that's why they all have T's in their names. Now look, the ones that have D's in their names are all right to left shunts. So VSD, usually left to right, because in general the left side of the heart has more pressure than the right. So if there's a defect in the atrial level or ventricular level, the normal passage of the blood will be from the high pressure to the low pressure area, from the left to the right. Same thing with the patent ductus arteriosus. Okay? The normal higher pressure is in the aorta. The normal lower pressure is in the pulmonary artery. So look, that's a D as well. So I think the D's and T's here are in order of frequency. Okay, that's why we had the color problem. So if I didn't confuse you enough already, let's do this again. There's three kinds of congenital heart defects. There's left to right shunts, and they all have D's in their names, whether they're defects at the ventricular or atrial or ductus level, or both the atrial and septal level, an atrial septal defect. That does not usually produce cyanosis because you're not really bypassing the lungs. But when you have a right to left shunt, you are bypassing the lungs significantly. And most of those have T's in their names, like tetralogy, the transposition of great arteries, truncus arteriosus, the total anomalous pulmonary venous congestion, and tricuspid atresia. These are blue babies. So do you want to say it this way? Do you want to say there's three kinds of defects? Blue babies, not blue babies, and babies where there's no shunting, but there's a significant constriction of one of the great vessels, like coarctation of the aorta or pulmonary stenosis. So those are the three things. And here's the general frequency. You can see by far VSD is the greatest one. You can see that ductus arteriosus is pretty big. Now, if you remember when we did the chapter on pediatrics, it said that PSD, or PDA, I'm sorry, patent ductus arteriosus was bigger than VSD, but they're both very, very big. I don't know why this one is bigger than this one, but I would believe this. In general, the left to right are much more common than the right to left. It's very difficult and rare to find a single gene anomaly in a congenital heart disease. Most of them are due to trisomies. We talked about a variety of congenital heart defects in Down syndrome babies, but also in trisomies 13, 15, 18. Some of these can be quite severe. We have a variety of congenital heart defects. What about Turner syndrome? Okay, a woman who doesn't have a second X chromosome. There's also a wide variety of congenital heart defects there. Sometimes when we do find a single gene mutation, it's usually a gene which encodes for transcription factors. And without knowing why they named these gene defects by these acronyms, let's just say the atrial and ventricular septal defects sometimes are associated with specific mutations of genes which encode for transcription factors. Remember when we talked about the valsocardiofacial chromosome deficiency, or a deletion of the long arm of the 22nd chromosome in this 11.2 region? We said that that was associated with congenital heart disease as well. So chromosome 22, especially at this level, is very important. Its deletion could result in conotrungus or bronchial arch deformities, and also facial deformities as well. This is the velocardiofacial syndrome. What are the causes of these problems? No big surprise. They're the same as the causes of any congenital malformation. Sometimes it can be linked to drugs, to diseases like rubella, to teratogens. In congenital heart defects, these are the two big things. Rubella, which of course is not very popular nowadays anymore. Teratogens would be the single biggest explanation, even if you can't find the specific teratogen. So here we go. We're going to say it again. The three types of diseases, the left to right shunts, they all have D's in their name, and because they're flowing from the left to the right side, they're not bypassing the lung, obviously, so there's no cyanosis. But because you are now having an increased pulmonary pressure because of shunting from the left side, you get pulmonary hypertension. And clinically, the most feared complication of a baby with a left to right shunt, no matter what kind of defect it has, is pulmonary hypertension. If it's severe, it may be irreversible, and it has a high mortality association. Now, in the right to left shunts, you're bypassing the lungs, aren't you? Maybe a little bit, maybe significantly. All of these congenital heart right to left shunts have T's in their names, okay, and because you're bypassing lungs and not getting oxygen and systemic blood, they're blue babies. So all the R to L's are blue babies. Some may be mild, some may be a lot. And think about it. If now you are shunting from the right to the left side and you have a venous embolism, that can now become systemic, can't it? Because you're bypassing the lungs. It doesn't lodge in the lungs anymore. It can go through the heart directly into the systemic circulation. The third type are obstructions of main arteries, and that usually refers to the pulmonary artery as well as the aorta. So, you know what? I probably should have made this thing yellow because I like this one the best, and I'm going to make it yellow right now by doing the format background thing, and we're going to say make it yellow because that's critically important slide. So, let's look at the 4 D's. They're all easy. The D's all mean defects, except for PDA, which is ductus. You have a defect in your atrial septum, producing a left to right shunt, because the left atrium has more pressure than the right atrium. You have a ventricular septal defect, in which there's a defect in the ventricular septum now, and that's shunting left to right because there's normally much more pressure in your left ventricle rather than your right ventricle. Or you could have a large one, and sometimes producing almost a single chambered heart, in which you have not only a large defect both at the atrial and septal level, but maybe not much of a septum even left. So that's called the ASCVD. Or, think about it, you normally have a patent foramen ovale, which is your ASD, or you normally have a patent ductus, but that soon closes off at birth. But if it remains beyond birth, you now have a defect at the level of your aorta and pulmonary artery, or patent ductus arteriosus. There's no cyanosis in these because you're not bypassing lungs, but what you are doing is putting significant increased pressure into the right side of the heart, and therefore the lungs as well. So whenever your pulmonary arteries have increased pressure going to those lungs, that's the definition of pulmonary hypertension. And once you have significant pulmonary hypertension, it's usually not reversible. So, what's the most feared consequence of any left to right shunt, no matter what D it is? It's pulmonary hypertension. Here's some models. I think these are all nice little graphs. Here's a defect at the level of the atrium, atrial septal defect. And if you remember looking at your heart in an anatomy lab and seeing a very, very thin, paper-thin defect between the right atrium and the right ventricle, that was your foramina valve, which is now closed. Sometimes they could be open if you just put a probe through there, but generally they're fibrosed at birth and they're permanently sealed. Here's a defect at the ventricular level, and just like at the atrial level, you're putting increased pressure into the right side of the heart, increased pressure into the lungs, possibly pulmonary hypertension. Here's increased pressure in the pulmonary artery due to a persistently open or patent ductus arteriosus, which should also close off at birth. So now you're having increased pressure in the lungs for that reason. Here's a significant defect at both the atrial and ventricular level, and it almost looks like a single chambered heart, doesn't it? And that would be a complete atrial ventricular canal defect. So there's it's like one big open chamber, and you have mixing of oxygenated with unoxygenated blood. And of course, here's a large VSD in which there is significant increased pressure into that pulmonary trunk, producing irreversible pulmonary hypertension, which is the most feared consequences of all left to right shunts, which of course are not cyanotic. Here's your atrial septal defect. Normally, your foraminal valve is patent when you're born. It usually closes the same time the ductus arteriosus does, soon after birth, within a few hours or a day, let's say. And sometimes it stays a little bit open longer than that, or because it's sort of a valvular membranous thing, sometimes it stays open forever, but because of the pressure, it's sealed shut. So an ASD is not just a theoretically probe patent foraminal valve, it's actually a defect. And most of them are at the level of the fossa ovalis, however. 90% of them. There's only a few of them that are in the mitral cleft a little bit further down near the AV valves. And of course, those are a little bit more serious than the ones that are just at the level of the ASD. But remember, it also depends on size as well. And also a few of them are in the sinus venosus. Remember that, next to the superior vena cava. And that can also be a theoretical area for an ASD. So remember, most of them are at the fossa ovalis, or that really, really thin part of the heart. When you dissected your heart, and you put one finger in the right atrium and your thumb in the left atrium, and you saw there was one little area about the size of your thumbprint that was paper thin. That's where most of them are. Ventricular septal defect, we said by far the most common congenital heart defect. Only 30% of them are isolated, and some of them are associated with a larger type of complex defect called a tetralogy of Fallot, which is the single most common right to left heart defect. But if you don't have the tetralogy, which we'll go into in a minute, you could have an isolated ventricular septal defect, and most of those are in the membranous septum, not the muscular part of the septum, but the fibrous, the membranous septum. Most of them. Some of them are in the muscular part, and if they're in the muscular part, they're more likely to have more than one hole, probably multiple holes. If you have a small, single ventricular septal defect anywhere, there's a very, very good chance it'll close spontaneously. If it's large, however, and doesn't close spontaneously, you know the drill. You know the feared consequences, pulmonary hypertension, because you're shunting a lot of high pressure blood into a low pressure chamber, and ultimately going into the lungs. Here's a VSD, and this is the membranous septum. Remember, this is right here, a direct communication between the right and the left ventricle. What about the other type of left to right shunt, the patent ductus arteriosus? Well, most of those are simply isolated, and they're not associated with other congenital defects. Sometimes you want to close them, obviously, but sometimes if you close them, you'd be killing the patient because of other right to left shunt thing. Sometimes the PDA is what's keeping that patient alive. You don't want to close those, but you do want to close the ones that are isolated, in which you might have the possibility of developing pulmonary hypertension. It's a harsh murmur. I tried to get the sound of it from one of the internet files, but it seems like everywhere I went to, they wanted me to pay money for the purpose of teaching you for free, and I have a real problem with that. The PDAs are also left to right shunts, but as your pulmonary hypertension approaches systemic pressure, it actually can go the other way. Now, closing the defect is obviously what you want to do if it's isolated. But if it's the only way for blood to get into the proper chamber with a right to left shunt, like in a truncus arteriosus or a total anonymous pulmonary venous return or a transposition of great arteries, if you close the PDA in that, they'll die. So sometimes you want to keep them open, you know, unless they're totally isolated, in which you want to close them. Prostaglandin E1 is basically the hormone which keeps that thing open in the prenatal period. And of course, one thing you might want to do is antagonize that drug before you do your surgery. And sometimes you could use a very good prostaglandin inhibitor called aspirin, which may help to close that PDA. AVSD, atrioventricular septal defect, is not just a defect in the ventricle, it's not just a defect in the atrium, but it's a defect in both, perhaps to the point where it doesn't even look like there's much of a septum there at all. It's very serious. If it's a complete atrioventricular septal defect, the patient basically has a 3-chambered heart rather than 4, you know, like reptiles do. And it may be associated with defective atrioventricular valves as well. Because think about it now. You have a very, very large cavity here, and obviously these valves have to be affected as well. So when you have a 3-chambered heart, or almost a 3-chambered heart, because of a large atrioventricular septal defect, you're almost always going to have some kind of valvular defect at the level of the atrium and the ventricle as well. Okay, take a deep breath. Because now we're not going to talk about the D's anymore, or the left to right shunts. We're going to talk about the T's, the right to left shunts. And the most common at the top of the list is the tetralogy of Fallot. It's also the single overwhelmingly most common right to left congenital heart disease involving right to left shunt. We'll also be talking about a few of the other T's, like transposition of great arteries, or truncus arteriosus, or total anonymous pulmonary venous connection, or tricuspid atresia. These are all situations in which you have blue babies because we have now shunting. Whenever you shunt from the right to the left side, remember you're bypassing the lungs. So you got to have blue babies. You got to have cyanosis. So when you look at the tetralogy of Fallot, which is the most common, you very often wonder, well, do I have to memorize 4 things? And my answer is no, because when you really look at it, it's really only one thing. You know, so somebody may say to you, well, name the 4 things of the tetralogy. We go, well, there's a big ventricular septal defect, there's obstruction to right ventricular flow, the aorta overrides the ventricular septal defect, and there's right ventricular hypertrophy. Well, that sounds like 4 different things, but when you think about it, it's really only one, and we're going to show you that. And of course, if you have a very significant stenosis underneath that pulmonary artery, it could be a very, very, very severe cyanosis, because nothing's getting into the lungs. But if you just have a small pulmonary obstruction, or not much, you can actually have a tetralogy in which the baby is not cyanotic. So that's the exception. You can have a pink tetralogy, but most of them, and of course all the severe ones, are cyanotic. Here it is. Now, you see these 4 things at the bottom? It's really only one, because think about it. Because if you have a large ventricular septal defect, and it's so large that your aorta actually overrides into the right ventricle, well, guess what? Your right ventricle now has increased pressure, so it has to become thicker. And furthermore, part of that thickness of the right ventricle is right below the pulmonary artery. The thicker this becomes, the more shunting there is and the less blood that's going into the lungs. So it's really only one thing, isn't it? I always objected to the fact that they called it a tetralogy. It's really only one thing. Let's look at another T. You have transposition of great arteries. Well, you know what that means. It means the pulmonary artery is where the aorta should be, and the aorta is where the pulmonary artery should be. Well, sounds like it's not too compatible with life, is it? However, if there's a shunt, like a PDA or a F or a patent foramen ovale, which there is usually, then that's how these babies survive. Or if the shunt is at the level of a ventricular septum, what they call a stable shunt, not likely to be unstable like this, then you have the baby allowing to live. Of course, this is very serious. It's usually fatal within the first few months. And as you would guess, because the right ventricle now has to bear the systemic pressure, and the left ventricle has now to sustain the pulmonary pressure, this is a case in which your right ventricle is thicker than your left ventricle. Because remember, we said that a ventricle is only as thick as the pressure demands it to be. The babies that are saved are the ones in which there's an actual surgical switching, and they take the aorta and they put it on the left side, and they take the pulmonary artery and they put it on the right side. These babies can be saved, but it's generally a very, very high mortality. And remember, just think logically. If you have transposition of your great arteries, you're dead unless there's a shunt. So that's why all these babies that are living or born alive, they have to have a shunt. And most of them are unstable shunts at the level of a PDA or a patent foramen ovale, which is pretty much the same as a PDA, isn't it? In this case, it just stays open. It's a patent foramen ovale. In this one, it's actually a patent ductus arteriosus, which is bigger, but these are unstable. If the defect is at the ventricular level, that's a little bit more stable. But they need surgery to live, and many of them don't. What about this other T called a truncus arteriosus? Remember in embryology, there was a structure called a truncus arteriosus, and it divided in half. And half of it became the pulmonary artery, and half of it became the aorta. And what happens if there's a defect in that division of the truncus? And now you have only one vessel. That's both the aorta and the pulmonary artery. It sounds pretty grisly, doesn't it? So in that situation, you would have to have a shunt at the ventricular level and mixing of blood to feed both the lungs as well as the systemic circulation. It's not a very common one, but think about it. If you had no division between the aorta and pulmonary artery, and there was only one big truncus left, you would have to have a single chamber, feeding both of those. And that's what happens in a truncus. I don't know how to correct that surgically. I know it's very serious. I know it's relatively rare. But I wish I could tell you exactly how we could save the baby in that case. What about tricuspid atresia? That's another T. It's another blue baby. It's another right to left shunt. Well, in a tricuspid atresia, if you are not opening your atretic or tricuspid valve, and remember, atresia is extreme stenosis. Stenosis means narrowing, but atresia means more than narrowing. It means the door is shut. So in a atretic valve, tricuspid valve, you don't have any passage of blood from the atrium. So obviously, from the right atrium to the right ventricle. So obviously, you need some kind of shunt to live. And the shunt could be at the atrial septal defect or a ventricular septal defect or patent. It could be at any of those three levels. It's very serious. It has a high mortality. And I wish I could tell you there's a procedure that, can save the baby. And I don't know how many of these are saved, but I don't think too many. Here's our last T. Here's our last blue baby. Here's our last right to left shunt. It's called total anomalous pulmonary venous connection. And what does that mean? It means the pulmonary veins don't go into the left atrium, but they go into the coronary sinus. And so think about it. If that's the really case, once again, you got to have a foramen of valve or a ductus or a VSD in order to survive. And because there's nothing going into that left atrium, you have a hypoplastic left atrium as well, because there's nothing for it to do. And remember, we told you that sometimes closing a PDA or a patent foramen of valve is good. Sometimes it's fatal. So let me ask you this. If this person had total anomalous pulmonary venous connection and the only way for that blood to get into the heart was through the innominate or coronary sinus, you would absolutely need that shunt to live. So if you close that person's PDA, they would die. So in most cases, in the isolated cases, you want to close the PDA. But in some cases, we've already seen 3 examples of it now with right to left shunts, that's the only way that baby is going to live. Our last and smallest category of congenital heart diseases are not shunts at all, but they are significant narrowings, or what you would call stenosis, or in the case of extreme stenosis, atresia, no opening at all, and at the level of the pulmonary artery or the aorta. So all of your obstructive, non-shunting diseases are either aorta or pulmonary artery. Here's coarctation of the aorta. It's a lot more common in men. Sometimes it's not even detected until adulthood. Sometimes if it's proximal to the patent ductus in an infant, it's very, very serious. It's a very, very common type of congenital heart defect in Turner syndrome. And think of it, in coarctation of the aorta, here's your aorta, you have a significant narrowing. That's what coarctation means. And in the adult form, which usually does not have a patent ductus, it's not as serious as the infantile form, which is proximal to the PDA, and it's very, very serious. And of course, you would need that PDA in order to live with this defect, wouldn't you? Just anatomically or physiologically speaking. What about the pulmonary artery now? Well, you can have pulmonary stenosis progressing all the way up to the very, very severe situation of pulmonary atresia. In stenosis, the lumen is narrowed. In atresia, it's narrowed so much it's completely blocked. So, if you have a 100% atretic pulmonary stenosis, you now have no reason for that right ventricle to work, and therefore you can get hypoplastic right ventricle with an atrial septal defect, okay? So in the babies with pulmonary stenosis or pulmonary atresia, their prognosis, their severity of their disease is strictly related to the degree of stenosis. So a stenosis is maybe livable, it may be even mild, but if it's an atresia, it's very, very serious, and it would wind up with practically no much of a wall in that right atrium. Right ventricle. It may be thinner than actually the atrial walls. Okay, let's see where we are time-wise. We're at 10:49. which means we spent the majority of the second hour talking about congenital heart diseases. I didn't really think I could get much into the ischemic heart diseases. Well, we talked about coarctation of the aorta, so let's talk about aortic stenosis, just like we talked about pulmonary stenosis. That'll give us another minute or two. In aortic stenosis, at the congenital level, remember, aortic stenosis can also occur because of valvular disease, because of calcifications of the aorta, because of rheumatic disease. But in the congenital form of aortic stenosis progressing to atriva, progressing to atresia, you can have the stenosis at 3 levels. One is at the valve, one is below the valve, and one is above the valve. Now, if it's at the valve and it's very severe, then because you wind up with a hypoplastic left ventricle, because there's no reason for that heart to pump or could pump, and it's a fatal situation. Hypoplastic LVs generally fatal. If the stenosis is below the valve, you're going to get an aortic wall that's thick below the cusps of the valve. If it's supravalvular, you're going to get this thickness and stenosis above the cusps and even extending into the ascending aorta. So an aortic stenosis, which results in ascending aorta problem, is probably supravalvular. And I hope that's logical too. So we're done with the discussion of congenital heart diseases. A pretty big section, and I thought I might be able to get into the ischemic heart diseases, which is going to be the majority of, maybe entirely, what we'll talk about on next session. And then we'll talk about the hypertensive, the valvular, and the primary myopathies, all of which have nice 3-letter acronyms, which look kind of stupid. It's better to just call them by their big names. And we'll do that on our next session. I don't know if I should say anything by way of introduction to ischemic heart disease, but this would be a good place to start on the next session. We'll talk about angina. We'll talk about myocardial infarctions. We'll talk about the difference between the two. We'll talk about chronic ischemic heart disease, which progress up to failure without evidence for infarction. We'll talk about the sudden coronary or sudden cardiac death syndromes. And then we'll talk about the acute coronary syndromes at all, whether it's just an unstable angina, an acute myocardial infarction, or sudden death. So I want you to kind of keep this in mind. In fact, just to help you keep it in mind, guess what I'm going to do? I'm going to turn it into a little bit of a yellow guy here, because I think that's a good general outline for the discussion on ischemic heart disease. And that's where we'll start on the next session, which will be 5 days from now. So that's 24 times 5 minus 2. I don't know how many hours it is, but that's when we'll see you. And now what I'm going to do is now save this little bit of an alteration I made, and close the window. And it'll close in a second, and I'm going to look to see if there's any hands that are up. Oh, it still doesn't want to close because there's a lot there to save. So you're looking at the flowers now. Actually, there's still a lot of you here on the attendee list. I'm going to see if any hands are up. So a lot of these names are looking very, very familiar. I really appreciate my regular customers here. I don't see any hands that are up, so I must have done a good job. I will also look at the question box in case some of you wanted to write your questions rather than speak them. And I don't see anything there, so I would like to think I did a good job. Maybe you're just sick of me talking and you don't want me to talk more, so we'll close the attendance and the question windows and progress with our last song from Forrest Gump. which is my second favorite Aretha Franklin song. See you in 5 days, folks. Rock on, you buzzards.